So our next speaker, I'm happy to introduce Dr. Alison Whelan, the Chief Medical Education Officer from the Association of American Medical Colleges.
Good morning. So I'm thrilled to be here. I had seen the panel of speakers, and I was really excited to hear what they all had to say. And as I expected, I think you're going to hear some overlapping themes and some different and complementary perspectives. I had not had the opportunity to see the list of who was going to be here. And as I stood in the breakfast line and then saw different people, I'm really looking forward to the discussion with all of you as well. Seeing some old friends and having been in the position that I'm in, a bunch of newer friends actually, and really wanted to congratulate NYU on putting this together. I think the timing and the focus for this discussion and bringing people like this together to really think about this important topic for a full day is really valuable, and appreciate you including us in really putting this together. So let me make sure I get this right. So I'm going to take a slightly different perspective and talk about some really pragmatic things, and then also sort of step back and talk about some broad domains that I think we should be thinking about in the UME-GME continuum. So in thinking about the transition to residency, there's two pieces. It's how you get from medical school into residency. So it's the choice, the application, the selection, the timing process, and then also readiness for residency, and with that, how we hand students off that sort of forward feeding of things. And then also the clinical learning environment, the physician is lifelong learning and what that means in the UME-GME continuum. And then really thinking about where most of the learning really occurs, which is in our healthcare systems and where they are in their continuum of learning. So when we think about residency choice and the application process, this is a huge pain point. It's a pain point for our students, it's a pain point for our programs. And I think we really do need to move to a more holistic, balanced approach with new and better tools and data analytics. And as Susan had mentioned, the AAMC has been leading some of this work, but other folks have been doing things as well. So what are some of the challenges? You can debate how we should be spending the fourth year, but that regardless of how students are spending their time, whether they're in a 3-year program, an accelerated program, a 4-year program, an MD, PhD program, there's a huge amount of time spent when they should be focused on becoming ready for residency and applying for residency. There's over-reliance on step 1, and students feel confused because there's lack of information about the programs, both what it takes to get into them and what the fit will be. And it's a huge burden for both students and for the programs in figuring out that match. So this is something we really need to fix, and it will help both the UME and GME world. So some of the things that we've been thinking about is how we help applicants apply more strategically, how we help medical school advisors counsel more strategically, and how we help program directors select more strategically. I'm going to move through these slides pretty quickly. There's details in them, but you have them as well. And the other thing that's important is we think about this whole perspective, and this is where some of the core EPA work is going on and where competency-based education is there's a real gap between the expectations of performance in day 1 of residency. And there's been data that's come from a number of places. So there was, in 2014, in the AAMC graduation questionnaire, we asked students, how ready do you feel you are for these? And then there was a survey of program directors saying, overall, how ready are the folks coming in? And as you can see, it wasn't 100% in students' perception, and relatively speaking, program directors felt that their interns were not ready for the first day of internship. This has led to a lot of work being done by many associations and by many medical schools. So it's the core EPA work, more competency-based assessment, but it's an area we need to continue to work on and continue to gather data and see as we make these changes and do these innovations, are we actually moving the needle so that the students are more prepared for the first day of residency. And then when we think about residency selection, I think everyone knows this. There's too many there's a lot of applications. The question is, are there too many? USMLE is the #1 thing that's looked at, step 1, in terms of filters. And that's not the be-all, end-all in terms of what really predicts and what program directors are looking for in terms of successful resident. And then for students, if you talk to them or you do surveys, they find the process really hard and overwhelming and confusing. And they don't feel like they have enough data to be making good choices about things. So the AAMC sent a survey to program directors, had about a 40% response rate, and said, you know, what are the most important selection criteria? And as you might guess, that there are things that professionalism, integrity, and those are things that we have the least ability to measure in the current things that are reproducible and available. So this needs to be an area, as we think about the UME-GME continuum, that together we really try to increase the number of tools and the availability of those. So in addition to that, the AAMC has been looking at doing surveys, so to say, how many programs do you actually need to match with? So in 2010, 2014, looked at a number of different specialties, broke the students out by US-IMGs, DOs, IMGs, FMGs, and this data is available on our website, so I'm going to move through it pretty quickly. And basically said, are there predictors of how many programs you need to apply to based on breaking down by big buckets of how people performed on USMLE by specialty? And then did analysis, and the outcome was, did you match to one residency? So as you can see, from 2006 to 2015, the number of applications has gone up a lot. And so for foreign medical graduates, it's gone up even more. So the question is, I mean, the assumption was people are doing too many applications. And the question was, well, shouldn't we actually find out if they're doing too many, and if so, how many too many, and how can we share this back so that both program directors and students and people who are advising students can make better decisions about things. So then asked a question based on that data, is there a diminishing point of return? So in this data, in this slide, it's a little bit small. The bottom is the highest quartile, and then moving up to the middle quartile, and then the top. And so this is US MDs graduating from IM programs, and that's the 3 bins of performance on step 1. And then looked at the number of applications, and then did they get accepted anywhere? And as you can see, for US MD IM graduates, there was after applying about 16 programs, you didn't get much bang for the buck. The lowest quartile, though, that number dropped to 31. So there is a difference. And if you look at the other data, so US-IMGs for IM programs, the numbers are different. So some probably aren't over-applying. And then there's same data for all 6 of the specialties, and we're continuing data analysis for all the specialties. This is going to be an ongoing project. We've posted this on the website. And it doesn't mean that, therefore, if you're a student, you should say, I need to apply to exactly 13 programs. But it does mean that you have a little better sense of where you fit into that huge scope of things. And you can talk to your advisor and say, okay, but am I more special? Do I have different things that make things, make me less competitive? Should I therefore apply to the median? Do I need to apply a little bit more? And really have a more informed conversation, which we think is really important. And the message here is, I think the more we think about assumptions we have and think about data that exists that we can use, the better we can help people make thoughtful decisions about things. And again, this isn't perfect. It's a relatively small sample size. It was only controlled for USMLE Step 1. We are going to continue to share this data, and we'll be interested in people's thoughts on what other information should be included in this. So other work that we are doing is the MSPE has been revised. It used to be 18 pages. No one read it. It was all very subjective. There were magic words or secret words, and tried to bring the data forward, make it shorter, make it more consistent, really be evaluation as opposed to a letter of praise. There has been modest adoption of it. More schools are taking it up. And the question really will be, can we look and see if people adopt the MSPE, does it help to holistic review? and can we further change it so program directors can actually use it? Because there is more data, including professionalism, within the MSPE that gets at those areas that program directors say are most important in the successful performance of residencies. A really small thing, most program directors, when we talked to them, said, yeah, we don't actually have a way of sort of telling people how they should be doing interviews, put together a short book for that. So I think there's lots of things that we can do to make the process better. And then very briefly, we are piloting the standardized video interview, which is looking at professionalism, communication skills. It was a pilot last year. This year it's an implementation pilot. All all emergency medicine programs are involved in this. So students do a video interview, answer 6 questions. It gets scored between 0 and 30 on professionalism and communication by trained raters. The programs will get the score, and they'll also have the opportunity to look at the videos. They're not told what they need to do with it. They're not told how to use it. But then we will be doing a survey to ask the program directors, how did you use it? Was it helpful? When did you use it? And then students will also be getting their scores. They will not get their videos, obviously, early enough so that they can actually use that potentially. You know, if you have a great step 1 score and a great SVI score, maybe you'll approach your number of applicants different than if you have an SVI score that is not so good. So we'll also be surveying the students about their perceptions of it and how they used it. So this is another tool for which we are gathering data to see whether it helps to really improve the holistic approach to this. So I already talked about that. This is more data than you need. It's in your slides. So again, I think building the toolbox so we can do more holistic review is really important. And then we're going to be spending a lot of time about this, but where does time variable competency-based medical education and the accelerated programs and the transition and handoff to residency fit into things? And truly believe we need to continue to think about what CBME is going to do for us so we can have greater readiness and advance at the right time, whether it's 3 years or 2.5 years or 4.5 years, and also time variable within residency. And again, thinking about competency-based education, it is across the continuum. And as Susan had said, we need to think about not just that drop-off at the end of residency, but, and the dean said, you know, training continues maybe 6 or 7 years. Most people would say that they're not really done, even feeling like they're competent in their specialty, until 3 or 4 years into their practice. And then medicine keeps changing, so it really, truly needs to be the continuum. So we're talking about the UME-GME continuum. We think it should look like this, and I'm going to be really pragmatic now. And I think it looks like this. And as we think about time variable competency-based education, and we think about accelerated programs, I think we need to think about the current context in which we're actually working and living and training right now, and think about how we can fix some of those things. And Susan actually mentioned some of these also. There's huge gaps. There's a language gap in CBME. So is it EPAs, core EPAs, milestones, you know, how does it all go together? We don't use the same tools on our assessment. So it's double work for our faculty, which is just tragic because they're already overworked. And I think in terms of expectations and this idea of feed forward are all areas that we could and should fix so that it's easier for our faculty, the handoff is better, our students are more confident and competent on that first day of residency, and our program directors are more confident that they're getting competent students and that they really know what their ability to perform is. So the way to do that is to implement the milestone and core EPA language, to really have students aware of what milestones are, and we could be pointing them towards the milestones. If I'm going to be a pediatrician, why don't I sit down with my advisors and coach and say, this is what you're going to be expected to do. It's your 2nd month of residency. Are you ready? Have you, are you focusing on those competencies or choosing your electives for that? And then importantly, we don't have a connection between our program directors and our schools back and forth saying, were they really ready? If not, where were they not? So that really in terms of readiness. And importantly, I think for program directors, they really need to be able to say, what you told me I was getting on my MSPE, what didn't quite match up, this is what you missed. And if we could do that, we would actually have a continuum of our educators, which I think would improve the continuum for our students and our learners as well. And then thinking about, how better tools for holistic admission and then feed forward is important as well. Then very briefly, I think this is the most important thing that we need to do. And it's to truly have an integrated clinical learning environment. As medicine has changed, as we've gone to an EMR, students have more often been sidelined as opposed to brought into the whole discussion of things. The schools that are part of the AMA consortium are working on that, and I think we need to continue to do that even more, and that we need much more collaboration at the UME-GME level. And I do think it will lead to greater wellness. So when you think about this, we think about the clerkships and advanced clinical rotations and clerkship directors and associate deans. They have required clinical encounters. They have core EPAs. We talk about student mistreatment. Residencies. We have interns. We have residencies. We have program directors. We talk about competencies. We talk about milestones. We talk about the clinical learning environment. They're exactly the same thing. And it's in exactly the same space. And not uncommonly, a student will have become a resident, and yet we use different language. This is another place we've got a language problem. We use different language. We assess it differently. We often have, if there's a reporting system, there's at least 2, sometimes 3 different systems in how we report that. And we don't really think about it as a continuum. The program director is thinking about the student who's a third-year student who may be accelerated, the student who's a fourth-year student who may be coming into my program, or may not be. But to really make this a single environment where all learning is thought as a continuum and together, I think will really be the best way to accelerate and move to competency-based education. And that we really need to shift towards truly lifelong learning and co-learning, because the ideas of health sciences services, health services science, I didn't learn that as a medical student. I didn't learn it as a resident. I think most of us didn't. And in order for us to both practice that way and importantly teach both our residents and our students that way, the faculty need to be fully involved in that and be part of the co-learning process. So I talked a little bit about this gap, and I know that we're really focusing about the UME-GME continuum. I think if we're going to close that gap, that in addition to all the things that Susan talked about, some of the things that I highlighted, that every single conversation, including today, really needs to focus on the CME-CPD continuum, because if we don't include that huge group of both teachers and ideally learners, we'll be missing the opportunity to really change the culture, change the environment, and drive learning. So right now, what's my vision for 2027? Is that if we continue evidence-based assessment of the impact of CBME and what works, if we increase data analytics about the residency process and about educational outcomes, and if we truly collaborate to create stronger connections across the UME-GME and CME continuum at the national level. So involving UME in the Milestones Project, creating a shared program director survey, which we are interested in leading and really have begun collaborative conversations with a lot of our other associations. Increased focus on an integrated continuous professional development to be absolutely necessary for the learning, to create a true learning health system, and for the culture change that's needed for better wellness, to truly implement competency-based medical education and time variable education. If we do all of that, then I think we will move to a more holistic, balanced approach to residency choice and application selection with new and better tools for data analytics. That CBME will really allow greater differentiated learning journeys, whether it's accelerated in 3 years, whether it's more variable and across the continuum. That a more integrated clinical learning environment will improve wellness and improve learning across the continuum. And that the health system and the community system really needs to be involved in thinking about what does the future of medical education look like, what do we need to have appropriate care. And that we'll have true culture shifts towards lifelong learning, and with that co-learning, the idea that a faculty member can be learning at the same time as a student, and that we'll be thinking and working across the continuum. Thank you.